I will start. I'm Simone Darouge. I'm an associate professor with the University of Ottawa. I'm a population health scientist, and my research program is focused on addressing inequities in access and access to needed services, as well as health inequities. So the ARC program we're going to talk about is part of my research program. So our intent is to build capacity in social prescribing. That's the intent of today's session. And we're working at a regional level, and we want to build a regional level that is scalable. So we'll talk about social prescribing where the navigator is centralized, so not inside the practices, and serves multiple practices. So emulating a little bit the kind of model that you've probably heard about in the UK. So we want to tell you about two social prescribing programs and how these two teams have come together to create a model that we hope takes the best of the two individual models and would be scalable. So one team is from Ottawa, and the model was developed in response to perceived inequities in access. And the other one is from the 211 Community Connection Group, and that was in response to a regional need. So let me introduce to you our speakers. Kiran Saluja is an anthropologist and global health researcher with more than 15 years of experience doing community-based action research, focusing on improving population health through health promotion, policy advocacy, and so on. She has a PhD and a postdoctoral fellow from the University of Montreal. Sherry Teeter, maybe you guys can wave when I mention your name, because right now I'm actually not seeing you, so let's make sure I see you. Okay. Sherry Teeter is the social prescribing and health initiatives is the social prescribing and health initiatives lead for the Community Connection 211. Sherry has many years of experience in healthcare where she utilizes her skills in project management and change management. And Pam Hillier. Pam is the executive director of the 211 Community Connections. That's one of the hubs of the 211 circuit, which I'm sure you're all aware of. And so it's an information and referral organization in the Collingwood area. Community Connection is part of the 211 and has many community-based partnership, which have led a little bit to this initiative. So let us begin. I'll ask you to tell us about how you came to establish your social prescribing program. So maybe Kiran, you can talk first.
Sure, thank you, Simone. So we started in 2015 when we were funded by CAHR CBPHC in an international team grant, which was to develop an innovation that really focused on addressing social determinants of health. So Ottawa was one of the Canadian regions for this program. And from some of our preliminary consultations that we had with patients and providers, we identified gaps in equitable access to community resources. Like patients, they told us that they have difficulty navigating the system, like they don't know what is available where and for whom, and things like how to register. They faced multiple barriers that they were not able to overcome on their own, and they needed support. Barriers like cost, transportation, finding services in their language, etc. And providers, though they are positioned very well to support the patients in the primary care, but it's really not possible for them to know all the resources that exist, and they often lack time. And at that time, most of the existing navigation models were really targeted to specific populations like new immigrants or elderly, or to specific health conditions. And we thought that a more effective action would be to develop a model that has a single point of entry for all So we ended up establishing a multi-stakeholder partnership that comprised of patients, primary care providers, social workers, as well as health planners. And together we developed access to resources in the community, which is a social prescribing model that focused on improving equitable access to community resources through patient navigation. And this group kept on meeting. They met like once in 2-3 months for say next 5 years. And the group actually helped to inform this intervention as well as the research phase and interpretation of the findings that we got. And I would like to mention here that we established the social prescribing model without knowing about this term. We did not have that language at that time. And in fact, I recall someone mentioning to us once that how Dr. Jennifer Reiner once mentioned to her that what you're doing is actually social prescribing.
Yeah, that's really important. And now it seems so obvious, but really this was developed independently of what we knew of social prescribing at the time. Thank you, Kieran. Pam, tell us about the Community Connection 211 program.
Thank you, Simone. And I'd like to use the next few slides to try to explain how the heck does a 3-digit dialing code and our organization named Community Connection get involved in social prescribing initiatives. So I just want to kind of give you the context for that, and Sherry will speak to actually the real work. So I just wanted to start simply that 211 is not an organization. It's really a dialing code. Here's a list of all the dialing codes in Canada. And the purpose of 3-digit dialing codes is just to simplify for the public what to remember when they need specific help. So it's just really that access to public information referral services. And we established the program way back in 2002 was the first launch in Canada. And since 2002, many things have changed. Next slide, please. And this is just, again, another visual of, we have the 211's a national number, we have a national network, we have a provincial network, but at the local level, down at the bottom, is where this particular program developed, is where we sit and get invited to tables and work on different projects. And this initiative came out of our invitation to work with the Health Links way back in 2015. And I didn't realize it was also 2015. So we both have that in common right now. So that's what, so I hope this slide just shows that while we are a call center for 211, we have many other activities that are going on that are related to working with shared services within our community. So next slide, please. And so this is a little bit of our evolution. Way back in 2015, when we were at our Health Links table, we were in Collingwood. So it was the Georgian Bay Health Links. And one of the community service partners, a support agency, suggested that, you know, it's really hard for all the different health-funded organizations to be known with all the physicians and the allied healthcare. And could we pilot a central referral service? So we started that work, and it, at the same time, was rolling out provincially the poverty screening tool with the Ontario College of Family Physicians. So all of this was playing out at this time. And here, when we started the central referral service, the family health team's physicians actually sent referrals before we even had the conversation around, well, what do we do when we get a referral? Because we're an inbound call center. And then over time, we developed our process on calling the patient back, using the right language, knowing that once they get referred to us, we don't call them a patient, we call them a client. So lots of learnings through our evolution. And we were working through this time with the allied health professionals in the Health Links, and they helped together. We worked through developing a more mature referral form and eventually an outcome report that was faxed back to the referring clinician at the time. And the next slide, please, is just a video clip I'd like to show of Dr. Gary Block. And we did some work with Gary at the provincial level with the poverty screening tool. And this is just his perspective on our work in social prescribing. So if we could play that, please.
I'm Gary Block, a family physician with St. Michael's Hospital and Inner City Health Associates in Toronto. My focus and interests really lie in looking at the intersection between social determinants of health and primary health care. And 211 has been an incredibly important partner for me in this work. 211 offers a flexibility of service and a willingness to innovate that few large organizations I've worked with have demonstrated. For me to be able to direct patients to both online and phone-based services that rely on the most in-depth repository of community service agencies and programs is incredibly important to the work that I do and incredibly important to the people I serve. I've been really excited to see 211 expand its services through programs like modified social prescribing programs, where they are willing to engage in in-depth social needs assessments and work with clients over extended periods of time to connect them with the supports that they need. I look forward to working with 211 well into the future, and I'm so excited that they are a partner in finding ways to bring social interventions to Canadians across the country.
What a lovely testimonial. I mean, there's nobody who doesn't know Gary Block, so that's amazing. We have a question. I think everybody appreciated that list of 3-digit numbers. Is there a connection, a formal connection between 211 and 811, Pam?
Not yet.
Okay, so
We're
thank you.
working on that and have lots of conversations at that level. Thank you. Good question.
Excellent. So maybe you can continue, Pam and Sherry, with your social prescribing program. So how does it work? How do you get the physicians on board? What does the navigator look like? What is this whole process? What does your model look like?
I'm going to speak to this slide and then I'll hand it over. Oh, I think I might. Yeah, then I'll hand it over to Sherry. So I just wanted to show out of our work on the right of the pie chart of the various, we do lots of different information referral pieces, but you can see this, the scope of 29% of our work is related to healthcare and these referrals and social prescribing. And paramedics have really been a part of that. And Sherry will speak to that work. But really the physicians that we've been working with particularly have been engaged through the family health teams. And it's really the allied health providers that have been really key to support the awareness of the referral form and the work we're doing. I think that's over to Sherry next.
Oh, you're on mute, Sherry.
Thank you. So I'm going to talk a little bit about what our program looks like. And so it really starts. So our program starts with a primary care provider who identifies that their patient could use some support with one or more of the needs of the social determinants of health. So they would send a referral from the patient's chart through the Ocean e-referral network to Community Connection 211, identifying the reasons for the referral. Then our navigator would then make an outbound call to contact that patient, who then becomes our client. And we try to do that as soon as possible, but definitely within the 5 business days, we do our first attempt to contact the client. So establishing rapport and building trust is one of the first things that we do, and we review with the client the reason for the referral. So our navigator would then start by doing an informal screening for other social needs that have not been identified on the referral form. For example, if someone is referred for housing insecurity, the navigator will also ask about things like utility payments or maybe food security. The navigator will work with the client to provide information in referrals that are appropriate to that need and can advocate on behalf of the client and connect the client through warm transfers if they can use some of that additional support. Details of the encounters are all documented in your client contact record, along with the needs and referrals that are provided, and we use this for reference for our follow-up calls. We offer continuous follow-up to all clients until the need is met or the client feels that they can manage on their own and they do not require a follow-up call. Some of those more complex clients will require multiple follow-up calls to get them connected. And once those needs have been met, we then discharge the client and send an outcome report back to the referrer. There it goes. Back to the referrer through the Ocean and into the patient's chart, closing the loop. For the paramedic referrals that come through Ocean, we have the ability, with the client's consent, to send an outcome report back to the provider, to the physician as well, so that they're always kept in the loop.
Okay, terrific. So there is a question about whether this referral pathway is available to any primary care. So are you, and Pam, you answered that you are open to taking new primary care practices as part of this pathway? Or yeah?
Yes, we are, but we would like to have a connection prior to any referrals starting, just so
yeah.
we can understand our partnership. But
yeah, absolutely. I think it's a whole program that we established. So right now your program is in Collingwood, but I really appreciate the question, because ultimately our goal is to make it available broadly across Ontario. But right now we have really worked within our little region. And I guess a report is sent back to the provider. Kieran, tell us about the ARC program. What does it look like? Oh, no. So here we go. So I think Sherry had one more slide.
I think Pam, you can probably speak to some of our navigator skill sets and trainings.
Yeah, so I'll just start. And this slide's to kind of depict what we build on when we have for our social prescribing team, because we do have a dedicated team that work only on our social prescribing, and we do some health navigation for Ontario Health teams as well. But on the left, it's showing that Community Connection is an information referral organization, and we're accredited through an international association called Inform USA, and it sets the standards for all of our work in our organization, which is really the foundation for information referral service quality. And that organization also provides a credentialing program for both our community navigators as well as our data curators, who are the folks that update our resource lists. So there's two different certifications. So it's really about broad human services in that skill set. And then our social prescribing team and our health navigation team, we've really worked on taking more time on calls and doing further assessments. These are particularly around because referrals we're getting are for vulnerable populations, and we can assume most of them have multiple issues and multiple problems. And so we really try to have apply trauma-informed principles, and more callers would need, or more clients would need, a warm transfer to an agency than most, perhaps. We also apply stages of change assessments for people that have multiple social needs. If they need food, we want to review their income levels. We want to see is their housing stable. So we work through that in a process that at the pace that the patient or the client can move. And we do a lot of empowerment conversations. And we're just emerging on some case conferencing where our team can work with another service provider and help to brainstorm ideas or provide the best service to those clients. So I think
that's great. Thank you. Thanks, Pam. So now, Kieran, tell us about the ARC program. What does it look like?
Yeah, sure. So ARC is a patient-centered, community-based social prescribing model that is embedded in primary care. And we utilize a lay patient navigator who is a generalist. One navigator can serve multiple practices, and she supports patients with all kinds of health and social needs. The model involves some practice-level adaptations, which may include things like identifying practice champions who could prepare the practices and also facilitate the program in the practices. And then we orient the providers on social determinants of health, as well as the breadth of community resources which are available, but they might not be aware of these. and train them to identifying patients with unmet health and social needs and making referrals. Adaptations at the practice level also entail things like placing promotional material about the program in the practices or establishing referral mechanisms, as well as arranging physical space for the navigator, because sometimes the first patient navigator meeting could take place at the practice, and these would always be in person, like the first meetings, followed by virtual meetings as the need may be. So the provider identifies the patients with needs and they refer them to the ARC navigator. Here, I would like to add that engaging providers to begin with, it was not an easy thing. We engaged physicians mostly through word of mouth and also use social media platforms like Facebook. And we also went on to identify some champions who led it and sort of brought in more providers and engaged them. And providers really needed convincing, but by the time we finished the program, they were very well engaged, so much that some of them didn't really want to leave the program. And talking about our navigator, so navigator is really the pivot of the ARC program. We developed a comprehensive training package for our navigators, which I'll come to in a minute. So about navigator's role upon receiving the referral form from the provider, the navigator schedules a meeting with the patient. And in the first meeting, the navigator actually completes a very comprehensive assessment in order to understand patients' barriers, their expectations, their readiness level, their priorities, and together they make a plan. So the navigator would identify the most appropriate resources at this stage. For that person, would also make some calls if they need to verify the eligibility of the patient and things like that. And if that fits, she would then explain the entire program to the patient. And she would also help patients access some barriers. As I was mentioning before, there could be barriers about transportation or completing forms or finding resources in the language of their choice, as well as providing empathy and building their confidence was on the navigator's role. And then the navigator reports back to the provider, ensuring that there's informational continuity and closing the case there. And to support their functions, we developed structured navigation guides and tools. And the navigator, they had some prepared scripts that could help her elicit some sensitive information if need be. And they also got some standardized data collection tools that were available to them. In fact, I was talking about the guides. So that we had 4 different guides developed. One was for the setting of practices as practice adaptations I was just talking about. And then there was a guide for explaining the entire navigation process and a separate training guide. And then there was one on the evaluation. So the navigator was trained to use a patient-centered approach, active offer, motivational interviewing, and to how they can provide long-term intense support to the patients, particularly the more complex patients. And the navigators also received ongoing mentorship and support for themselves. So they used to have regular debriefing sessions with their mentors. So these are some of the guides I was mentioning about practice setup, and all these 4 guides are available on our website if someone wants to have a look. And there was a separate training guide, which was very comprehensive. It had 12 modules, and it takes around 24 to 26 hours to complete these online. And our team has actually trained several navigators outside the ARC model program as well. Like we've trained CHCs, navigators from CHCs, or Children's Hospital of Eastern Ontario, and also navigators for refugees program in Australia. So this was just a description of our program and what we do.
Well, thank you, Kiran. Maybe you can go on and describe what evidence you have on the benefits or the impact of this program. So was it successful? What were the key factors and so on?
Sure. So in 2018, we assessed the feasibility of our model that we developed across 7 areas in a single-arm prospective BICS method study. We looked at the demand, process of implementation, integration and adaptation, its practicality and acceptability. And this study demonstrated that ARC was very well received by patients, and it was very much acceptable to the providers. It could easily be integrated into the primary care practices and was highly valued by non-interprofessional practices. So there were 2 types of practices who participated in the feasibility study. Interprofessional practices who are shown in yellow here, and non-interprofessional practices who are in gray here. So as we can see, most providers in both the models, they reported that the program increased their awareness about community resources and it encouraged them to make referrals. For navigation services, particularly looking at whether the services met patients' needs and providers' expectations, non-interprofessional practices highly valued the ARC services. So more than 90%, we can see that they thought it met providers' expectations. And similarly for the processes, non-interprofessional practices rated the navigation services very highly. Majority agreed that the services were timely, they were coordinated effectively, and the navigator's role was very well defined. Interprofessional practices, their experience was rated a little lower, possibly because they do have a social worker or a navigator within their practice who's readily available, so patients, they may not have to wait for long or face any coordination challenges as such. And then in 2019, our team designed a prospective mixed method randomized control trial where we compared ARC navigation services to the traditional Ontario 211 navigation services. Ontario 211 is a freely available telephone and online navigation service. And this study was funded by SPOT and Ministry of Health. And we conducted the study in 2 regions, Ottawa and Sudbury. ARC was an intense program compared to the 211, and we expected it to perform better, but we really wanted to quantify it to understand how much it worked and for whom it worked. So access was clearly higher for patients who were randomized to ARC arm. And this study also demonstrated the benefit of ARC navigation services in reducing the access inequities across education level, as well as achieving better language concordance of services for the Francophone patients. So here, patients who were randomized to ARC arm are shown in red, and those to the 211 are in blue. And we asked them about their experience with the program. And patients, they highly valued ARC's patient-centered approach, and they reported higher benefits from the services compared to the 211 navigation approach. Like 72% said that the services really met their needs, but this number was 26% for the ARC arm. And patients were highly satisfied, and more than 90%, they wanted to use the ARC services again. Here's just a snapshot of one of our patients who said, as before ARC, like she didn't really know how diverse options were available and how the navigator helped her. So we also asked them about their experience with the navigator, and patients rated the navigator highly for their intense, long, continued support and how they addressed their barriers in accessing the resources. I think what worked here is the fact that ARC navigator stayed on with the patient, provided in-depth support at length, and the use of these standardized forms, including the forms to assess barriers and even document their barriers, priorities, and make a common action plan together with them. So it really helped. So here's another another patient who talked how the navigator provided intense support to her. And then we asked our providers about their experience with ARC. The providers also perceived large benefits from ARC, and they told us how ARC services encouraged them to identify their patients with needs and even making referrals. It increased their awareness of the community in the resources, which we also saw in the feasibility study. And in fact, 90%, if more than 90% said that the program activities did not interfere with their practice functions. We also conducted rapid cycle evaluations for the first few months, and we asked the providers how the program was going so that we could make any necessary changes if required.
That's great. One thing that I'm trying to answer questions online as well. Lots of questions, so I'm delighted. There's lots of interest. I want to point out that the 211 comparative arm is that traditional 211 where we told patients, you know, you've been allocated to the 211 services. We told them about it, and we gave them the phone number, the website, and encourage them to follow up. So that's very different from the social prescribing program that Pam and Sherry have been telling us about. So just to be clear on that. There was also you raised an issue around these interprofessional teams, and I know that our community connection colleagues also have questions around the role of these programs in supporting interprofessional teams. So I hope to bring that back at the discussion. So maybe now I'll turn it to Sherry. And I know that as a program, you're not set up to do in-depth evaluation the way research programs do, but maybe you can tell us about what information do you have on the, I think you call it closing the loop. So it's very different from the traditional 211. So on your social prescribing program, closing the loop.
Right, thanks, Simone. Yeah, so if you take a look at this data we gathered from 2017 to 2022, you can see the percentage of increase. And the first row is our referrals from our healthcare providers. We've had a 40% increase there. And the bottom row is our paramedic referrals that we've seen a 315% increase there over those 5 years. Largely, I mean, I think this speaks to the value of the program and the need to help residents, individuals connect to those social resources. But over the years, we have broadened our reach, and we have partnered with 3 paramedic services in surrounding counties and an additional community home visiting paramedic service. And we're continually reaching out to medical clinics and increasing our providers that are referring to us. And you're going to speak to the outcomes from our
So I'll just add, for community connection, our level of our vision and our mission is really around shared service delivery and partnerships and where we can support and help. It's not around analyzing the data as much. So that's what we're learning with our partnership with ARC is the value of different things. So I'm showing you some data that we have. This one is a report we received from the County of Simcoe related to their paramedic referrals. And it was between 2015 and 2021, and it was analyzed from 911 calls for patients that specifically received some level of support through a referral to 211. And the analysis was based on a comparison of 6 months pre and post referrals for 569 patients. And the analysis shows a 28% reduction in repeat calls to 911 for paramedic services. So we know through our partners that this isn't the strongest level of evidence in pre and post evaluation, but it's really encouraging. And our programs are funded through municipal dollars, local dollars, not health dollars, or it's not funded through 211 Ontario. These are local funds and local resources, and these kinds of numbers are really encouraging to our local politicians and our county councils that deliver community services. The next slide is just a really high level of like why people are. These are a mixture of both calls to 211 and our social prescribing. So these are just from a caller needs or our client needs in Simcoe County. It's just a little snapshot. I think it's 2022 data. I can't remember for sure, but just to give you a sense of on the left is where our high level category of need, and we can drill those down with a taxonomy to five layers, so I could go deeper. So we've just rolled this up to make it very simple. But you can see our top need to call to 211 or referral is health related. So that could be many things. So we've given the top 10 examples on the right. So sorry, the second need is housing, which is no surprise. So the top 2 are health and housing. And then we've just shown like what we mean by the need. So when they said health, what the heck did they need? So the top need was medical expense assistance and referrals and home health care, health education. And so that's where our referrals would have been for these type of calls. Just to give you a sense of that, we can drill this down to postal code and very deeper levels. We can also show what services did people ask for that had unmet needs due to various barriers, wait lists and transportation and things like that. And it's those reports that our municipal partners are looking for, our United Way funders are looking for. It helps to show a needs and trends in community around the service at the community level that's available.
So we're running a little bit behind schedule. I really want to make sure that people have an opportunity for discussion. So maybe I'm gonna. I do think the conclusions are important, but maybe I'll ask you to be just a little more succinct, so we can, because there are lots of questions. Okay. So next is then, well, what are your conclusions? Where do we go from here? So Kieran, your program showed really interesting benefits. I love the equity impact. Tell us about it. Tell us about your conclusions and recommendations.
Yeah, sure. So yes, it was effective, but it involved high costs. So we wanted to be more efficient, and it improved equity. So we learned from Ontario 211 that it was adequate for patients who are less complex, but we also note that for more complex patients, ARC-like support, intense support is required. So we are really looking for a 2-tiered system here. And the model needs to be sustainable, and we don't want another system to be created. So we're really looking forward to integrate the model and the best practices from ARC into an existing system, and also the broader goal of reaching more broadly. And the current approach in the practices for screening the patients is actually based on providers' now knowledge about their patients. What we are recommending is using a more active method of screening, using a questionnaire around things like food insecurity, housing instability, etc. And these patients could either complete a questionnaire on site, or they could be sent on their emails. We're also considering identifying patients who have social vulnerability based on their neighborhood level data that we can extract. We can flag these patients in the EMR. That could be one way of identifying patients as well.
Okay, thanks. So more efficiency, maybe better screening for better uptake. What about the community connection folks?
Right. Yeah, I think we certainly recognize some opportunities for growth, and looking at standardizing our processes and our tools, enhancing our navigator training to include more motivational interviewing and stages of change. We certainly think that the opportunity to do an evaluation on our program to demonstrate the impact in a more formal way will be very helpful and credible for us as well.
Okay. So Sherry, maybe follow up and tell us about, so these two teams have come together, each finding in the other something they felt they were missing. So for us, you've got that amazing infrastructure, and you're continuing to invest in that infrastructure. You've got the database, you've got the personnel, and more importantly, you're part of the system. You're already in the system, or at least 211 is. And so we didn't want to produce something in parallel, and you wanted to do more rigorous evaluation, learn from the work we did in the practice and so on. So the two groups came together and we're producing a combined model. What does it look like?
Yes, that's great. Thanks for that intro. So but that's exactly right. We're taking the best out of the two models, and we're merging them together to have this integrated model. And it's going to look like, you know what, Kieran, it's not working very well.
There we go.
So, okay. So the practice adaptations is what Kieran has already spoke about. So I'm not going to go into too much detail there, but it's certainly we're going to focus on really onboarding the practices and preparing them for the social prescribing program. The next one is we're going to increase the amount of motivational interviewing that our navigators are going to receive, adopt ARC's best practices to standardize our approach with the clients to include the scripting, some great custom forms, documented goal setting that can then be emailed to the clients. We're going to connect with the client within 24 to 48 hours. We're really hoping to mitigate the number of clients we're unable to contact by reducing that cycle time. We're going to use ARC structured forms to help and understand the needs, the barriers, and the priorities. We'll also be implementing a social needs screening tool. So this will be new, and this standardized tool will alert the navigator of any additional social risks that the client can maybe benefit from some support. And from that social needs assessment tool,
maybe Kieran, you could help by clicking.
Thank you. Perfect. We'll trigger this risk rating tool. And this will help us to standardize and identify the appropriate resources based on their level of complexity for that need. So an individual can fall, and click that please for me, can fall on a continuum on this 6-step scale somewhere between crisis and thriving. And each risk level will be linked to the community resources that allows us to evaluate and for that need, and it'll allow us to evaluate the impact and change over time. So we're really excited to have this additional tool.
That's fantastic. Oh, sorry, go ahead. What are we going?
So then we're also going to provide that informational support that'll address their barriers to support and provide them with emotional and empathetic support. And our community connection has really transitioned from a 211 call center anonymous database into a longitudinal social record to better support the client. This new technology is customizable for data collection or the region that we're servicing. And all these tools and processes, we really believe will provide some valuable data, not only for supporting the client, but for coordinated care planning and future population health planning. And we're also going to be doing a rigorous evaluation as we want to establish a value of the program to scale up.
Because that's really what the policymakers, those who can fund us, that's what they require. So that'll be great. I think we're going to stop here because the rest was a little bit of self-reflection, but we've got 12 minutes left and maybe we could stop sharing. We can put the slides up again if people want to look at something in particular. But let's, I know one of the things that we wanted to discuss, and I know we've got a lot of folks from interprofessional teams here, how did this model, because we kind of conceived it as especially helping those, what we call the solo practitioners, because they've got no support, no capacity for support internally, but we also can serve the interprofessional practices. So that's one thing we can talk about, but I'm looking for questions from the audience here. Oh, here we go, Anna. Now, put your camera on. Anna, can you? I'd love to speak. You've made such great comments. I feel like, we should get to know each other. If you can, don't let me. There we go. Hi.
I had a question around caseload. Some of it was answered in here, but I'm wondering, somebody answered that it was the group of researchers who were the navigators in the ARC project. I'm just wondering how that would translate into the new landscape of OHTs and serving multiple practices, and how that would look if we were to try and do that kind of a program. What's the caseload like? How many navigators did you have? What kind of patient population were they serving? Yeah.
So the navigator could carry, if I'm right, 10 patients at any one time. I don't have the whole data, but I know our conclusion was that we needed to be more efficient. One, we need to have patients who have less needs, who are less complex, go through that process more quickly. They don't need that level of support. And the success rate with the traditional 211 arm tells us that they're quite capable. A good bunch of them are quite capable. So we need to focus on those, spend more time on those with higher needs. And the community connection group is bringing all this information technology advances that is going to improve efficiency. So can I tell you exactly how many? I don't know if you have any data from your Closing the Loop, Sherry and Pam, in terms of capacity. How many patients can a navigator see?
Yeah, so from our, we kind of did a sort of an analysis of how many, what is the average length of call. In our call center, we have the ability to track all of this great information so we can assess that. And so we are able to sort of know we take 8 new patients a day, but we keep within that 5 business day service level agreement. And then, as our volumes increase, then we do bring on more navigators to fill that.
So I'd have to say that, Community Connections program was probably more efficient. We dealt with very complex patients who stayed with us for like 3 months of support. So it really depends on the complexity. But we are working with 2 Ontario health teams that we're hoping to bring this into, and in the Eastern Ottawa area. And I'm hoping to interest the ministry in piloting this across other Ontario health teams as well. So that's where we're at with that scale up. Cleo, hi Cleo, good to see you here. How did you get funded for the Closing the Loop program? Pam.
I was just typing that in. I didn't know how many we could answer at once. So our social prescribing work is funded locally through municipalities and United Ways right now. We are piloting it with our Ontario health team. So Community Connection is an anchor partner and 2 health teams in our region. And that's where a lot of this digital ideas and the digital tools and the ocean integration came from, is our work with Ontario Health and being more efficient and effective with how data moves around. And we also are looking for the demonstration. That's where this partnership with ARC to really give us credible data on our work, and really it's our work within it's our work in community, not as the only partner. We're just one of many.
Sorry, go ahead, Cleo. No, go ahead, please.
Do you think the government or municipalities are interested in, so first of all, the municipalities in long-term funding, and is the government interested in expansion?
We've been receiving funding from Municipalities United Ways since that we started this quite a few years ago. And that's where the paramedic data is really key. And paramedics were making a referral for the same patient to a physician, a clinic, and to us all at the same time. So our data helps us to say, well, how does that all work? And who's the best one? And that's where all these ideas came from. So I think we have a lot of work to do on the efficiency side. And really why the value of working with Simona and her team in this work is going to be really helpful to get how we fit within the healthcare structure, because our work also helps homeless populations and our work also helps mental health patients. So we're kind of in this broad area. So good.
So I'm going to say there's lots of questions. I have trouble reading them and getting back here. Please just go ahead and tell us your questions. And if we don't have time to answer them, please write to us. We're quite keen on collaborating with people. And I do want to tell you that the ministry is interested in, so I spoke with the director of the social determinants of health for Ontario Health. They're interested in finding a social prescribing program that could be scaled up, maybe multiple is what they said. how is that going to happen? It's not entirely clear. I know that there are 12 Ontario health teams who are doing demonstration projects, right? So in there, I do believe that they have funding for navigation, but so I know there's extra funding coming with it. So if there are teams, the accelerated, thank you, yeah. So if there are Ontario health teams who are keen on trialing this, just contact us and we'll figure out how we can do it. So, Anam, are you with the Ottawa OHT, the central one?
No, Nipissing Wellness up in Northern.
Oh, Nipissing. Oh, okay, fascinating. So we should definitely talk. Somebody asked, and maybe I'll ask this question to Kieran. So who is the navigator? We said they're a lay person, and they gave examples of people who could be navigator. But Kieran, from your experience, who's the perfect navigator? What do we look for? What characteristics do we look for when we hire the navigator?
Sure. As I said, for the navigator, one who uses patient-centered approach, is being very well trained in motivational interviewing, understanding the needs and attributes, who's one also trained to provide different kind of support, like informational support, as well as instrumental support, as we call it. But basically it is about if the patient is not able to, for example, find a way to address their barriers, the navigator really provides intense support to address those barriers and provide emotional support. And also one key attribute that our navigator had was offering like active offer for particularly those who wanted to use French. And our navigator was a lay person, as you said, who was non-clinical, a generalist, and accepts patients for all kinds of health and social needs, health as in non-medical.
So I know that, so we did, qualitative data collection as well. And I couldn't tell you the number of patients who cried during their interview because of how they felt supported by the navigator. It is unbelievable how many patients feel the gratitude of being heard. So I think, someone who's empathic, somebody who wants to have a connection with people, that makes a big difference. And in terms of, supporting their self-empowerment and just allowing them to enable that self-efficacy. So a people person makes a big, big difference. Yeah, thank you. What else? We've got a couple of minutes. One last question, but you have to say it because there's too many things for me to read on the right-hand side. Well, I can see one from Tara. So what are the challenges you expect for Ontario health teams? And maybe this is, Sherry or Pam, where you can talk about the importance of context and understanding the context where we're working, doing an asset mapping, understanding what's available, because maybe you can talk about the limitation of the database that 211 has. I mean, it's a fantastic database, but what do you do when you're working within a community?
So I can take that start, Pam, and then you can add in if you want. But I think there are two opportunities that we have as the environment is changing, and all for a good thing. And one certainly is our navigators that are being link workers that are being funded to be more sitting in the clinic, which I think is really helpful for those complex clients that can receive some of that support right at the clinic that they know and they support. But it doesn't have to be an or, like them or us. We really see it now being more of an and. And is there an opportunity to partner with us and maybe send us those lower acuity patients that can be helped over the phone? And we'd still do that continuous follow-up, and we'd still send out those outcome reports back so that they know that. But certainly the opportunity to let us help support some of those patients. And then the other one is that the database. I know that 211 is often been criticized for not having a complex list of all the community resources. That database does contain over 60,000 programming services, but sometimes the organizations do not respond to our request for their data to update their records. And so it is one of our challenges. But when we work with our community partners, we do some asset mapping and some targeted outreach to those gaps in resources that we identify. And we've noticed that sometimes when our partners have reached out to those organizations themselves, particularly if they have a relationship, they tend to then respond to complete that 211 data. And we see that as a win-win for both of us, really, that we have that resource data that's available to all individuals to help the next client. And plus, our data curators can keep that information up to date ongoing. They do this at minimum of an annual. They reach out to these organizations so that all of these DHCs and FHTs do not have to collect this data on their own and keep it updated. Yeah. That we can really be that source of truth.
I want to echo what Jane is saying here in the comments, is that, and that's what we do. That's what the ARC project did. And I'm sure that's what you did within Collingwood. When we're working within a region, we go more deeply, and from word to mouth and from, making phone calls, we do try to identify the assets that are available in that community that would not necessarily be in that provincial database. And so it's important to work with the community because they will know. So, maybe some like the CHCs might know what some programs that exist that we had not been aware of. So, yeah, it's important. It's a partnership, right, to support them.
Absolutely.
Is there someone from the conference? Because I think we're meant to stop at 1:40. We're happy to stay, but I don't. We might get kicked out. I want to thank everybody for your enthusiasm about this and your great questions. And I'm actually going to ask for somebody from the conference to give us the comments. Hopefully that's all saved, and maybe we can do some more networking, but do feel free to reach out to us. Thank you so much for your participation. Thank you for our panel members. It was great. I found it very helpful the way you've presented things. Thank you.